clinical background, the angio, and the IVUS run. Can I have a brief discussion and then discuss about the case? Thank you for inviting us to the 8th iPCI. Can you increase the volume? Thank you for inviting us to the 8th iPCI 2025 conference. My name is Dr. Chirag Parikh. I'm an interventional cardiologist at the S.R. Mehta Kikabai Cardiac Institute here in Mumbai. With me is Dr. Chinmay Kulkarni. With us, we have our entire team with staff nurse Shreya and senior cath lab technician Rajesh and Santosh. And we have Rohan from Philips. So today we'll be presenting a live in-box case. These are our disclosures. Next slide. So today's session objective is predominantly to understand the Philips Sync Vision systems, which integrates all the physiology and imaging modalities, especially the IVUS and IFR modalities into one package, in addition to certain additional features which are available, which we will be demonstrating to you. So our patient today is a 34-year-old male. He is an active smoker with no other risk factors. He has undergone angioplasty to his proximal LAD in 2021. With probably a 3021 stent. He presented to us with a NSTEMI about 7 days back, and his ejection fraction is about 45%. His angiography was done, which shows that there is a distal edge ISR in the previously deployed stent in the proximal LAD. The ostium of the diagonal branch has a tight stenosis. Both the LAD and the diagonal branches show some hazy appearing lesions. There is a minor plaque in the ostium of the LAD which doesn't appear to be significant. The circumflex appears to be normal. However, the RCA shows a borderline stenosis at its proximal bend, which needs further evaluation by physiology. And as you can see, there is a stenosis in the proximal RCA near the first bend. It doesn't appear to be very significant on angiographic appearance, but what this intrasite system also provides us, we can perform a quantitative coronary angiographic analysis. This is the Sync Vision screen which you can see in front of you, and you have certain columns on the right hand side which are for the live cine, for the recorded angiograms, for the device detection, for IVUS, and for physiology. The thing that we are going to do for this patient is we are going to perform a QCA. So we have a 6-French guiding catheter in the RCA, and we are going to trace through the vessel enhancement. We are going to trace the vessel borders, and here you can see that we are getting a lesion estimate of around 40%, but we will confirm this also by performing IFR. We are now advancing the pressure wire, which is a Verata pressure wire, into the vessel. The newer version of the wire is now available, which is called as the Omni wire, which has a significant better torqueability. A very important thing to remember while performing any pressure wire study is to always remove the needle, otherwise that can give rise to fallacious readings. So we are now advancing the pressure wire beyond the lesion, and general rule is to advance the wire about 2 vessel diameters below the lesion. So as expected, the IFR in the RCA is 1. So I think the RCA can be left safely for medical management. That's the run from the LAD. I can just play that again if you...
If can I interrupt?
Yeah, I think we can have discussion.
So if you have an ISR like this, what is your choice? So if you have IVUS, which modality you choose?
So OCT is
And why?
definitely better for tissue characterization in terms of deciding whether it is a neointimal hyperplasia or it's a neoatherosclerosis. But I think you must do some form of imaging rather than waiting for the perfect imaging. So if we had IVUS available in the lab, I think it's better to do IVUS rather than not do any imaging, because IVUS would still give us a lot of information in this case.
I think that's the best way to go for any stent failure. Always do imaging, whatever you have. That is the most important. So what is the interpretation of your IVUS?
Sir, I think what I was told is we'll have a discussion and I have the video where I have my interpretation.
Focus on the distal edge, beyond the distal edge, where the lesion is there. That is very
So
important.
there is a very beautiful demonstration of,
Yeah.
because it's a fellow's course, the myocardial bridge is also seen very beautifully on the mid part.
That area of interest.
Yeah.
That's the myocardial bridge segment, where you can see that bridging part, and then we can come to the distal edge. The syncretion system works best with, go back to the old video, please. Now let me control it from here, please. The syncretion system, I'll control it from here. Thank you for inviting us to.
So Chirag, when you did angio, what did you suspect? You know.
So there are a lot of differential diagnosis of this lesion, because it could be a recanalized thrombus, it could be a predominantly lipidic plaque. It is unlikely to be calcium because he is a young patient. There doesn't appear to be any angiographic calcification. But the last possibility would be a spontaneous coronary artery dissection also cannot be ruled out.
He had ACS.
He had a ACS presentation. So recanalized thrombus would be on top of the cards. But we cannot rule out in ISR. It can be a lipidic plaque or it can also be some form of spontaneous coronary dissection in this young patient.
Dr. Chirag, when did he undergo the first angioplasty?
4 years back.
So first
4
was
years.
2021.
4 years ago. So it could be a neoatherosclerosis,
Yeah.
which behaves like an accelerated atherosclerosis, could be a plaque rupture.
So the most important thing is timeline. Again, the most
Timeline.
important thing.
Most important
if
thing is
patient
the
is
time.
coming to you in a 1 year or 2 year, you should start thinking about NIH. Now after 4 years, in such a young chap, so
Can I invite Dr. Akasaka on the dais, please?
So we will suspect aggressive atherosclerosis.
Atherosclerosis.
Yes,
Neoatherosclerosis.
neoatherosclerosis leading to maybe rupture or a stent acute thrombus formation or recanalization. So again, it starts from the clinical picture and timelines. That's very important.
Only there, actually, when you say neoatherosclerosis, the development of the atherosclerosis inside the stent. This is outside the stent.
This is peristent.
Edge called edge restenosis.
Edge restenosis.
There is a selective terms are there. Stent edge restenosis. That means when you land in a improper landing zone, especially if there is a geographical miss, most likely lipid-rich plaque. So that's the reason when you implant the stent, see that your landing zones are less than 50% plaque burden. Especially lipid-rich plaque should be avoided. In such cases, the restenosis rate is very high. Here, stent appears to be fine. The minimal neointimal thickness is there, but there is no evidence of any atherosclerosis inside the stent. This should be called as a stent more looking like a lipid-rich plaque. Lipid with some necrotic core, ulcerated. So that is a classic diagnosis. So that is the reason this needs only additional stenting distal edge.
Sir, what about the diagonal branch? What is
That we'll go through again, play it and see. Play it.
So how was the areas of LED?
Sir, the
You
MSA was 3.8.
Again, proximal LED,
Yeah,
3.8.
3.8, but
So that is with the tissue inside.
Okay.
I think the stent areas we will come to that. Yeah. Some hazy appearing lesions. There is a minor plaque in the ostium of the LED which doesn't appear to be significant. The circumflex appears to be normal. And better to remember was that and general with the lesion RCA. So that's the angio. So, the guideline. So I think the RCA can be left safely for medical management. So what would be the 0-1-1 sort of, means it's not exactly a true bifurcation, but if the proximal part, angiographically at least looks okay. Diagonal ostium and distal to the diagonal appears to be disease. So what would be the consensus for stenting in this patient? Would you do just a DCB to both the vessels? Would you want to stent just the LED and leave the diagonal? So
Yeah, the stent edge, stent edge has no problem. Beyond the stent edge, the vessel
so
looks normal.
there is disease inside
have
the stent. Yeah.
Stent edge.
I will.
If you don't have any additional disease in the stent edge, you can just manage the DCB. This is my opinion.
Well, there is restenosis inside the stent also, I will show.
But ideally, always SCR, stented resistance only stenting. And stent,
Now this is inside
stent also lesion is there. There you can go with just beyond stent you go. Distal edge of the stent.
But this is where the normal segment is.
Then still
Maybe little
you can
distal to
come.
that.
Still you can come. Still you can come.
And now
Beyond stent. Beyond stent. Still beyond
that's
stent.
inside the stent.
That is inside stent. You can come.
And now this is the
Stent.
diagonal.
This is appears to be.
You don't have the stent edge problem. It's inside the stent. It's a distal. Yeah. In those cases, you can modify the lesion, and DCB is a good option for those. We don't have a systematic data available, though there is a class 1 recommendation for DES nowadays for the ISR. But I think this science is evolving. You can go with a DCB rather than going for a second layer. What Dr. Akasaka will tell you.
For the distal edge, you are showing only stent. That
Compared with
Yes.
DCB, I think the DS should be the better in the report, I think. But now we try to do the DCB in these cases. We want to have the data.
actually stent resistance DCB ideal choice inside stent. Only they have recommended, Sky recommended in between some gap is there, additional stent, under expansion, over dilate, and edges restenosis, additional stenting, stent fracture is near, additional stenting. There are certain criteria. But I'm not sure whether I think angiovis is looking distally, but we are unable to see. But the inside stent only, cutting balloon, go with the DCB of the, including hybrid strategy. You can go with the DCB of the diagonal also.
I think for the fellows, we may divide it two things. Is it a mechanical problem or a biological problem?
That's
And how many,
This
how
seems
many
to be-
layers of stent are there? That's very difficult to make out from the IVUS alone. If it is OCT, we can make out little more better. But if it is only a single layer of stent, and it's a predominantly biological problem like a neoatherosclerosis and a plaque rupture,
Stent is
yes, is better rather than DCB.
But
If it
in
two layers of
proximal
stent, no question, it is DCB. We cannot make out a very difficult to make out neoatherosclerosis.
That's the limitation of,
IVUS.
this, conventional IVUS. Actually, IVUS and OCT would have given us a better picture. The biggest fight that we are not able to see actually, stent failure, high definition HD, I think it's always better if available, and OCT definitely.
For my experience is, we get lost in the IVUS. In most of the new operators, they get lost in the IVUS. It's very difficult to find out where you are in the angiography when you are interpreting the IVUS run. And that is where I have found that actually this system gives me the most ease is I can exactly pinpoint in the angiography because it is a fantastic co-registration which happens, which allows me to know where in the artery I am seeing the IVUS. And then that helps me to plan the procedure much better. I agree that we lose a little bit of tissue characterization in terms of it's a 20 megahertz catheter.
No,
The other thing which I find is in India, we don't have a separate imaging analyst. Most of the times, imaging is done by the operators. And with the high definition IVUS, we are dependent, most centers are dependent on the company person
No, no,
to
no,
do
no,
the
no,
analysis.
no, that's wrong.
That is
So
also
Chirag,
one thing.
Chirag,
No, I totally agree.
how we work as an imager is we see our images by us only. We see it. We deglove, we go to the console, we do, because you are dealing with stent failure.
Yes.
Now it's very important first to identify why this stent has failed. He had a ACS. You are going to do something, either DAS or DB, and we at this stage, 34 years of age, we don't want to take any chance. So, if possible, we always deglove. I always deglove, go to the console. I see personally, I take 5-10 minutes.
Dr.
There is
Chirag.
no, for this 34-year-old chap who is lying on the table at this age, proximal LAD, it's very important to see the image in detail. Make up your mind why this stent, if the stent has failed or it's a disease ahead of the stent, it's a new atherosclerosis, what is the plaque composition, choose your device and put your stent accordingly. This is the most important thing.
I agree with that. I 100% agree
And
with
you
that.
don't have to rely on the technicians or company guys for the imaging. You have to see it yourself if you want to improve the outcome.
I think
of
that
using
is the
image.
biggest take home
Yeah,
message.
that's the
We
most
have to do
important
it ourselves.
So all fellows, you should learn imaging and you should do it yourself, not what he or she is saying on the.
Is before putting the catheter, you should have a question in your mind what you want to see.
Exactly. Exactly. So,
Okay. So here, co-registration is not important for me. I want a resolution to know the plaque characteristic, and my management depends on that. Whether I have a stent expansion problem, whether I have a fracture problem, whether I have a new atherosclerosis or NIH. So those things are important for me. So if everybody is not fortunate to have a OCT system so if you have an ISR, I would say undoubtedly OCT has a better resolution and better idea. But high definition IVUS is equally good.
Yes.
And you can manage an ISR definitely. That ISR being treated with high definition.
And if you don't have both, yes, the great thing is you are doing it, but take time to identify.
Yeah, we can go ahead.
Yeah, we
and
can go ahead.
Next. But
Syncvision system Syncvision system works best with the eagle-eye catheter. It's a 20 megahertz catheter, but what I really like about this catheter is that it's a plug-and-play system. We'll be performing a pullback under continuous fluoroscopic guidance. It's important to find a suitable fluoroscopic angle where the entire length of the artery is visualized with a gradual pullback rate of about 1 to 2 millimeters per second. And as you can see on this catheter, there are 3 dots which can be used to measure the length in case you do not have the Syncvision system. And the distance between the 2 dots is 10 millimeters. The next thing we do is we perform an angio co-registration. So without moving the C-arm, we need to take a cine shoot. The co-registration of the angiography with the IVUS. We can see 2 white dots and a yellow line and a yellow marker. So the 2 dots represent the distal and proximal edge of the IVUS co-registration. Now this is where the plaque is starting. So we can bookmark this as a distal reference, vessel lumen in this portion, and the reference diameter is about 3.1. So we would probably undersize by 0.25 and take a 2.75 millimeter stent. I'll come to that distally. And then we can continue with our run. And here you can now very beautifully co-register the images with the angiography, which cell diameter is around 3. So considering that he had a 3O stent, he has actually received a adequately sized stent. And here we can see that there is a lot of lipidic areas inside this
probably there is a plaque rupture.
plaque, which probably represents why he had an acute coronary syndrome. And the previously deployed stent is quite well expanded. It's a 3O stent, which is expanded to 3 millimeters. MS minimum
Rupture plaque makes it a new atherosclerosis.
new atherosclerosis. So there is an entity described called as lipidic new atherosclerosis. I think that's what, and that has poor prognosis.
And we do expect this in this case,
This case.
34-year-old having CAD, aggressive atherosclerosis.
Coming more proximally, I think here there is not much tissue, and here the stent appears to be pretty well expanded and apposed. I think based on these IVUS findings, Chinmay, we can put one stent from the septal branch just below the diagonal into the mid LAD. The sync vision allows you to do is it allows you to measure the angiographic length based on the IVUS co-registration. Then we would be okay if we had a 16 or 18 millimeter stent. To the diagonal branch, if we feel that the angiographic result is good, then we can go for a kissing balloon inflation with a DCB in the diagonal. Strategy will allow us to do also is to avoid a double layer of metal at the diagonal bifurcation in this young patient. Now predilating this vessel with a 2.75 15 non-compliant balloon. System is the device detection, wherein you can, any device which has two radiolucent markers will be automatically detected by the device, and so this saves a lot of fluoroscopy and radiation exposure. So I am at 14 now, and again in the device detection we can see that the balloon is well opened up. So another feature of this sync vision system is something called as vessel enhancement. So here, if you just go on the angiography and you right click on the vessel, then it will automatically enhance. Here you can very beautifully see the diagonal bifurcation. So we are now going with a 2.5 NC balloon in the diagonal branch and go up on the balloon, and I am now going at 12. I think I'm happy with this landing. To the 275/60 stent. So I'm at 12. Yeah, looks good. So we are now taking a 2.520 paclitaxel DCB into the diagonal branch, going to 8 atmospheres. And I think we have excellent result here. So we have a 2.515 non-compliant balloon in the diagonal and a 3.012 non-compliant balloon in the LAD. That's the post. We are at the distal edge and it looks good. There is no obvious dissection. Now we are in the overlapping portion. That's the diagonal wire coming in. Now in the proximal LED. Seem to have landed in a reasonably healthy part of the vessel. There is no distal edge dissection, and the stent area at the distal edge is 7.3, which is quite acceptable. And now coming more proximally, you see that the stent is well expanded, and we are at the overlapping portion of the two stents. We can appreciate the two stent layers, and here we have again an area of 7.3 and a diameter of 3. So good stent expansion, good apposition, no edge complications. And now just before the diagonal branch, I think this is where we will have our minimal stent area. So 6.8, which is again more than 90% of the distal reference. So we are okay even in the MS net. And that was the final angiography. We had a small dissection at the ostium of the diagonal, but it was for dye staining or there was TIMI3 flow, so we decided to accept that. The case.
Yeah. I think Chirag, that's a fantastic case. But only two things, like when you're for fellows, if you have taken imaging, you have taken out the imaging catheter, you have to use it at the fullest. So there was haziness in the diagonal. In my opinion, one should always image it, number one. Number two, you are planning to do DCB, always prepare it well. And at the, once you have got an imaging IVUS catheter on the table, we should not rely on, okay, there is no haziness, no dye staining, and it's always better. It's always better, especially when you are doing no new modalities, using, DCB. You want to see what was there. Because there was haziness at the distal edge of the stent, there was haziness in the diagonal. I was curious to see what is actually happening at the diagonal? Was there any lipid-rich plaque? Because you have got a imaging on the table.
Because we debated that, but we had already done IFR and a lot long procedure.
So there are 2 points in my. One is any ISR, as we are discussing, we have a diagonal issue. You didn't come across the diagonal.
I did not want to
avoided the diagonal, but we don't know the area above that. We didn't see so well.
No, area about that was reasonable, sir. I had to fit everything in 6 minutes, so I.
Second thing, there was a distal muscle bridge.
There is a muscle bridge.
As we are putting another stent, we are going closer to that muscle bridge. So we are most likely maybe entering into the muscle bridge and the area of muscle.
I can show you on IVUS.
Yeah,
we are far away from the bridge.
And how many of us in this hall they believe DCB is a good option? How many of the people are doing DCB in ISR inside the stent segment, not at the edge? So DCB is a good option, but it's your choice. You did it nicely.
But it was not purely inside the stent. There was disease outside the stent, which is why I chose for a DES.
Because for new atherosclerosis is a bad news always. Whether you are doing DCB or a second stent, this is going to happen because it's a new disease in the new intima. So anything will not be good. For NIH, the drug-eluting balloons are really good. But for new atherosclerosis, whether you are putting a second stent or a DCB, both are equal. There is a small Japanese study where second stent is better.
Actually, to conclude, ISR lesion always fellows are there. You have to identify the cause. Is it a mechanical factor? Is it biological? Is it drug related? So mechanical means under expansion, stent fracture. So if these are there, if you are missing between stents, overlapping is not there, or overlapping, these are mechanical causes. So severe calcium under expansion. Suppose drug related, like a polymer related, the early phase, as he mentioned very clearly, first 2 years neointimal proliferation, beyond 2 years neoatherosclerosis. In the neoatherosclerosis, usually first phase is lipid intima, second phase calcific intima. Calcific intima very easy to identify because inside stent you see the calcific shadow. Lipid intima usually one side, so that is hyperlucence, low intensity signal. There you can see, and usually stent edge register starts at the edges and it spreads inside. That is edge register extending into the, and classical is a lipid rich intima and ruptured. That you can see the filling defect very clearly. And the last view showed very clearly, distally it is there, extended to the distal portion of the stent. So, if more than 2 layers of stents are there, there is a wonderful study from Zhang series, more restenosis compared to DCB. If you put more layer of stents, onion skin appearance, so more restenosis. Side branch, DEB plus stent, depth side is there, biolic study is there, definitely restenosis rate is less.
I think it's the disease which is coming back with a vengeance. It will again come. It will again, because he is only 36 or 38. So until and unless we conquer the atherosclerosis completely, there is not a definite complete answer to this thing. But always, whenever we do the procedure, do the perfect procedure. That's all we can do about this.